Hello there. Well, welcome and thanks everybody for tuning in for this British Society of Lifestyle Medicine videocast. I'm Dr. Rob Lawson, a former NHS general practitioner, co-founder and chairman of BSLM, and also president of the European Lifestyle Medicine Council. In this videocast, across a series of episodes, we are bringing you personal, engaging and informative discussions with health experts from around the world, covering a range of topics related to lifestyle as medicine. Today, it is my great pleasure to introduce you to Professor Robert Thomas. Now, he's a consultant oncologist at Bedford and Addenbrooke's hospitals, a clinical teacher at Cambridge University, and visiting professor of sports and nutritional science at the University of Bedfordshire. He's lead of a lifestyle and cancer research unit designing government-backed studies evaluating the impact of exercise, diet, and natural therapies. In collaboration with the universities of Bedfordshire, Southern California, Cambridge, and Glasgow. This unit has published over 100 peer-reviewed scientific papers. More notable studies have included the world's largest randomized controlled trial of a polyphenol-rich nutritional supplement in patients with cancer, the POMI-T trial, and the randomized evaluation of a topical therapy to prevent chemotherapy-induced nail damage, the POLYBALM study. More recently, he led the analysis of the 150,000 patient dataset PLCO, which has linked tea and broccoli consumption with cancer prevention. He and his colleagues have designed and is currently conducting the UK's COVID-19 nutritional intervention study, the PhytoV RCT. It is assessing whether a blend of prebiotic polyphenol-rich foods plus or minus a yogurt plus probiotic would lower the severity and duration of symptoms. In 2010, he led the implementation of the UK's cancer exercise rehabilitation course and qualification with Macmillan and Skills Active. And in 2019, he wrote a book, Keep Healthy After Cancer, and remains medical advisor for the lifestyle and cancer website, cancernet.co.uk. The general lifestyle site, also keephealthy.com. And he writes a popular health blog in partnership with health professionals and nutritionists. For these contributions, he's been awarded the British Oncology Association Oncologist of the Year and the Royal College of Radiologists Medal. So congratulations, Rob. That's a great accolade, I'm sure. And incidentally, at Cambridge University, he scored the highest grade, namely Outstanding Clinical Teacher, from every student for 3 years running. Now, he didn't include that in his bio, but I'm throwing that in because I think that's an even greater accolade than the one before. So, Rob, thank you very much for agreeing to this conversation, and welcome to our BSLM videocast. And I'd like to start off with a really easy question. First of all, I have trouble spelling broccoli, but do you actually like eating broccoli?
I always mix around the C's and the L's like yourself. I don't like it when I cook it myself or it's been boiled for 3 hours, that's for sure. There is a skill with cooking vegetables, many vegetables, particularly cruciferous vegetables. But if I get my wife to cook it or go to a nice restaurant, yeah, you can. You have to be careful with how you cook it. If you overcook it, you can destroy some of the healthy ingredients. But yes, I do enjoy it at times, especially knowing how healthy it is.
Yes. I have been asked in the past, and I'm not a nutritionist, I don't know the answer, but you will. Is broccoli better raw or cooked? And if it's cooked, is it better done in a microwave or steamed or boiled? What's your advice?
Well, different brands of broccoli can be better than others. You know, the sprouting broccoli is supposed to be particularly healthy. There's one of the polyphenols called myosin, which is destroyed by the cooking process, and that helps the absorption of the healthy nutrients called sulforaphane and indole 3-carbinol, which are the things supposed to have the anti-cancer properties. So it is important. If you just have heavily boiled broccoli, you're going to miss out on much of the benefit. So, but you can have that, what is called myosin, in other foods which tend to be eaten raw. So myosin is present in salads, it's in radishes. So I always advise people when you're eating broccoli, either to try and have a little bit of raw alongside the cooked version. So maybe sprinkle a little bit in salads or cut it up for a salad, or have a salad with a meal containing broccoli, which has things like radishes, etc. So yeah, you have to think a little bit about it. Just having a load of boiled broccoli, you're going to miss out the health benefits.
Now, I'd like to start, Rob Thomas, with your past, and what was it that led you into medicine? I mean, as a schoolboy, what did you think as you were going through your school years? Yes, do I really want to be a doctor? How was it that you came to that conclusion?
Well, it's a good question. I'm not sure if I really know the answer. I mean, I grew up went to a comprehensive school in South Wales, and career guidance was not really on the agenda. And my father was in the RAF in Scotland, actually. And so I had a choice of the RAF, a lawyer, a doctor, or an engineer. And that's all we sort of knew what university was. These days, when you see people in university, there's all these really interesting degrees. And I wasn't particularly good at physics. I'm not particularly good writer, although I write a lot. And that sort of left medicine, really. So that was how I made the choice.
And what is it that, well, are there any other medics in your family, or were you the only one?
My father's second wife, actually, was an anaesthetist in Glasgow. Oh, so right. Yes, I did come across her, and she was quite inspiring. But I just saw it as a stable career. It's nice to help people. It's a rewarding thing. So I thought, well, look, that looks good. You're never going to be out of a job. You get to help people, and it's very diverse as a career. Every day is different. So I haven't regretted the decision at all.
Wonderful. I think most of us do go into it because we think we are going to do good, but along the way somewhere we may have taken a diversion. But anyway, what sort of career-changing events or influencers have there been that you can share with us?
Well, I mean, I suppose the biggest change on the research side was to start developing a lifestyle medicine, nutritional strategy. And that sort of wasn't just an overnight sort of euphoria type moment. It was originally, it was when I started as a consultant, and in those days these jobs are banned now. I mean, to go into a busy DGH and suddenly have 60 patients a day on your own as your first consultant job would be illegal, I would imagine. So there was very limited time to speak to patients. And in those days, there wasn't Macmillan or lovely leaflets which you could give people. They didn't exist. So the first thing I thought, we will need to develop information strategies to give to patients to help them make the decisions. And that's when we need to prove also that giving information actually helped people, because it wasn't actually known back then. So that was the big decision. I went into developing videos, booklets, working with patients and finding out what information they want to know and what they don't want to know. And that was quite rewarding, in fact. It showed some major changes in patient satisfaction. We're able to talk to empowered patients, so they were better skilled up to make decisions of their own. So that was a big change for me. And then from there, it then led to other ways patients can help themselves. And that led on to exercise, diet, nutrition, and all sorts of other things.
What are you finding that, I mean, we talk about, in lifestyle medicine world anyway, about this sort of behavioral change aspect and the motivation to change. And we talk about taking advantage of an extrinsic motivation and developing it into an intrinsic motivation for change. How have you viewed that sort of element of behavioral change in your approach to what you do?
Are you talking about like the sort of teachable moment type thing, or
what is it that, I mean, in your research of how patients reacted to what you were doing, and you observing how they responded in the change of behavior, what are there obvious light bulb moments that you seize upon that you recognize?
Yes, I mean, it's always longer than you think, probably about 8 years ago, we conducted a study looking at men with prostate cancer and how much exercise they did, whether they were overweight. And we were actually quite staggered back then that only 4% of men exercise more than 3 hours a week, which is the sort of an official cutoff where you start seeing some anti-cancer benefits, and 70% were overweight. A lot were, pre-diabetic or diabetic as well. So it became very obvious that there was a lifestyle element to that disease. So we've worked very hard on that, but understanding, it's not a case of just telling people to exercise or change their diet, but understanding the barriers to exercise, what things are going to sustain an exercise program for longer, how they would want to change their diet. So a lot of the research we've been doing is to try and to make changes which are going to be sustainable. But that's the challenge of lifestyle medicine. It's not as easy as people think. And there's been a number of studies which we can talk about later, which has helped us achieve those goals.
I think that the word lifestyle itself has hit the headlines recently. I think some in our profession don't like the word and associate it with this blame culture. That we're accusing people of not looking after themselves and blaming lifestyle. That of course is not where we are at all. But I mean, have you yourself come across any of that sort of pushback?
Yes, very much so. It's also part of the skill of a consultation is not to sort of start with, you're here because you've smoked, or you're here because you haven't exercised. I mean, certainly in my talks, and you do the same, I've noticed, you say, we are not here to blame people. We're here to sort of explain the research and the links and empower people if they want to change. If they don't want to change, that is entirely their prerogative. In fact, that's the first sentence in my book, saying, I'm not here to preach to you, but to guide. And, it's well known, if you start preaching at patients, they usually do the opposite. So, but when we always start with this sort of reason why they're there, talking about the radiotherapy, the chemotherapy, etc., surgical options, and then usually bring in towards the end of the conversation, okay, we've discussed that. Would you like to talk about strategies to help yourself? Or often the patient will bring those up themselves. That's even better. And then it's a lot more receptive. But you're right. Occasionally, and over the last 15 years, you'd have, I get very few complaints, fortunately, despite the fact that my patients don't get much time. But now and again, you get saying things like, oh, he didn't give me chemotherapy. All he was doing was talking about, losing weight and exercise. But I can remember 2 or 3 patients over 20 years who've actually found it offensive to suggest that a lifestyle is part of their management. But it has to be done carefully, because, they're primarily coming to see you because they want some, drugs or chemotherapy or radiotherapy, and to turn around and suggest, well, we'll try other options first. It can be thin ice. You have to tread carefully.
Have you detected any change over the last 10, 20 years in terms of people's approach and patients' approach now? I mean, are they more receptive to this conversation than they used to be?
I think you're right there. And a lot of that is driven by organizations such as yourself and publications in medical journals. 20 years ago, it was very rare to see anything about lifestyle in a medical journal. Now, most journals will have 1 or 2 papers each issue. So it's becoming more talked about. So patients don't find it a complete surprise. In fact, quite the opposite. They very much welcome it. I mean, that's most of them say, "Oh, thank you, doctor. Nobody's talked about these things before." So I don't think any other doctors listening need to be scared about breaching the subject. Yeah. And Macmillan are doing nice information leaflets now, which are handed out about how to lose weight, how to exercise more, how to improve your diet. And you see those leaflets all over the cancer units as well. So it is becoming easier and I think more mainstream.
Yeah, we're pushing much more at an open door. Certainly 30 years ago when I embarked on this, there was pretty much a closed door. It's beginning to open, but we've got a bit to go yet. In terms of the current, you're going from the past to the present. How are you spending most of your time in the cancer care world?
What, during COVID or
no. Just as an employee in your career, how are you spending your time as a cancer specialist?
Well, I work in 2 hospitals. So I work in Addenbrooke's in Cambridge, where I teach medical students on a Wednesday, which is very rewarding.
Yeah.
And then I do the radiotherapy there. And the radiotherapy, I have to say, over the last 5 or 6 years, there's been a technological revolution, and it's great to see these fancy machines. I mean, they look like Maserati sports cars now, and they can just knock a spot off the moon without, so what that means is the toxicity of treatments is dramatically dropped, which is nice. So it's nice to have that science in your life. And then in Bedford, where I work, I see patients with all sorts of diseases, from advanced, palliative care to men with early prostate cancer. So again, very, very busy clinics, seeing new patients, follow-ups, supervising chemotherapy, and more the biological treatments. I did a tally the other day, and actually 60% of the patients I see on treatments are now not chemotherapy. They're these CD4/6 inhibitors or these monoclonal antibodies, all with their own unique side effects, which we weren't experiencing before, like lung toxicities and skin rashes and heart damage. But that leads us on to, that's the nice thing about being an oncologist. You actually have to be very much a generalist, because you're giving drugs which could affect their blood pressure, their heart, their lung status. So you have to be sort of fairly up to date on how to manage the illness of a patient. So it's changing every month. It's changing.
We talk about a personalized approach to medicine. It sounds as if, are we heading in that direction already, that we can personalize it to that extent?
It's I mean, it's becoming. Every patient now, you look at their genetic profiles of the cancer and the patient itself to determine which drugs are best for them. So 10 years ago, there was breast cancer and you gave that chemotherapy and that's it. Now you're looking at whether they've got inherited disorders like BRCA1 or BRCA2, where the tumor is overexpressing different genes. And you have to target specific drugs and specific biologicals to that profile. So it makes it much harder and slower, to get the treatment started. But of course, the treatments are much more effective and for that individual. But the problem with the NHS is they haven't reduced the time it takes per consultation. So you find yourself, rushing more and more. So they need to address that. The patients are more complicated to treat. They take more time and there's more preparation, but the outcomes are better. I
mean, the other side of this coin, I think, is the personalized, yes. Do you think the delivery of it can be done in groups, like group consultations, for example, which is what we promote a lot, because there are a lot of common drivers here, which can be addressed in that group setting while still making it a sort of one-to-one clinical encounter with one individual. Is that something that you have an experience with or feel might be of help in the future?
I really enjoyed your talk in Edinburgh in your last conference. I think it was someone from the London School of Economics, wasn't it, who was driving that?
Yes.
I mean, it does seem, I see a lot of men on active surveillance for prostate cancer, because that's a type of disease which is very amenable to diet and lifestyle strategies. You can slow it down and prevent needing any interventions. And it seems silly that you see 15 men in a day and you have the same conversation with each of them. I mean, obviously whether they go on to radiotherapy or surgery, that's a different individual conversation, but it does seem a good idea to sort of group everyone together and have the lifestyle chat at least, and then have a smaller conversation. But I did go back after your conference and talk to my managers and things, and they got a little bit scared of it, and I don't think they're quite ready for this change yet. We do have prostate groups, so we give talks as a group explaining about lifestyle strategies, and we go out to the bowling club and the tennis clubs and golf clubs, and we have a self-help group. So we are able to get the message over. So when we then speak to them in the consultation, it is quicker because they've often heard the talk separately.
And how is the sort of COVID era, how is that, excuse me, impacted on how you can engage with your patients?
Well, like all things, there's every crisis has an opportunity. It's bad that patients are presenting later. We've had some, pretty bad breast cancers with fungating disease and things when they should have presented because they were scared of coming to hospital. Same with men with urinary symptoms. So there's been some delays. Obviously, a lot of the surgery has been cancelled, which I couldn't really understand why. But anyway, all the prostatectomies are cancelled. We've carried on pretty much with the radiotherapy and chemotherapy, to be honest. But on the good side, we've thought very hard about some patients where it was probably inappropriate to give chemotherapy, and we've had to think twice and not given it, which that's a good thing. And the fractionations for radiotherapy, such as, for breast cancer, we normally bring people up for 3 or 4 weeks. And we've managed to shorten it to a week, which evidence-based, based on European studies, etc. So we fast-tracked all those changes which involve shorter regimes, which is good for patients. The telephone conversations can be a little bit annoying. I had one complaint, actually. There's another complaint in the last year because they felt the consultation wasn't very good. And it was, so you haven't got that face-to-face interaction. But I have to say most men and women are quite happy. You have to rely very much on them. Of course, you can't examine breast lumps and you can't do rectal examinations. So I don't find it 100% satisfactory, but there are cases where you don't need to do that. And of course, there's knock-on effects. It's generally quicker, so you can see more patients. They're not driving to the hospital, so they're not polluting the atmosphere and taking up parking spaces, there's always a massive problem parking around hospitals. So actually going forward, we're not going to stop telephone consultations. We're going to keep those going in certain groups. So that's a good thing. So it's it's not all bad.
No, I think that 30 years of change has happened in about 3 weeks. I think that's the sense you get. Suddenly we're all wanting to speak on the telephone and do video consultations. Whereas I think hopefully we'll find a happy medium where we do actually still continue to see patients face to face. During this time, it's been hard, hasn't it, in many ways. But how do you keep yourself fit in the 21st century, and especially during the COVID era?
Well, even if you are worried about going outside, I have to say I think the risks are overstated. But nevertheless, if you are worried, there's plenty of parks. Most towns, one good thing about Britain, we have lots of parks and things. And I think the chance of catching COVID walking in a park is very slim indeed. You can't go to a gym or a dance class or a bowling class, which is bad. You can play golf now, which I've noticed is started. Gyms, I've always been suspicious of gyms, to be honest. I go to the gym occasionally, but the air is recycled. Whenever I go on a treadmill, I come out with a cold or a cough. I think we need to improve the ventilation in gyms.
How about you do a lot of international talking, so you must do a lot of traveling. How do you enjoy the traveling in airplanes?
I think I was the last one out of Finland just before COVID, and I was on a deserted plane. Apparently, according to an email I saw from Ryanair, they do filter the air, and you can't actually catch it from the air conditioning like we all thought, but you can catch it from the man sitting or woman sitting next to you. I can see that's concerning. Obviously, a lot of the research we did for our COVID study we looked at very carefully at people who had other comorbidities. I mean, if you're under 60 with no comorbidities, the probability of getting a fatal COVID infection is, less than 0.1%. So, and I'd like to see myself in that group. So I wouldn't be scared of catching COVID. I wouldn't want to. But for the vulnerable groups, the diabetic, the overweight, people with respiratory or heart problems, I can see it is a concern, and maybe they should stay off traveling for the moment.
In terms, that leads on really to your current research plans. What can you tell us about them?
Well, there's a number. Thanks to your help, we've done an analysis of a very large data set of 155,000 people followed for 15 years. And what we wanted to test three things in that. Based on our original POMI-T study, which found a supplement had a prostate cancer protective role, but we wanted to see if there would be any evidence that things like tea or broccoli would reduce the risk of getting cancer in the first place. Particularly that there was a paper a few years ago suggesting tea might increase the risk of prostate cancer. But it grouped tea in a number of different things, including soya and all sorts of things. So it gave it a bit of a bad rap, and I thought unnecessary. And I enjoy drinking tea, so I wanted the answer as well. So we basically asked the question from the data set: if you drink tea, do you have a lower risk of prostate cancer 10, 15 years later? And we were pleased to say, yes, it did. There was about a 3 to 5% reduction in the risk of prostate cancer if you drank more than a couple of cups of tea a day. And we published that, virtually in ASCO recently. And that was done with Glasgow University statisticians. And we did the same thing for broccoli, which showed that, again, if you have on average a cup of broccoli every other day, which is well within most people's abilities, you get a reduction in all cancers, which is good. I mean, broccoli, we sort of knew it was healthy anyway, so I don't think the journalists were rushing to take that story. We had some interest from the tea, in view of the negative press last year, but again, most journalists only like negative stories, so but you probably didn't read about it in the Daily Mail. But what it's given us the incentive for and the motivation, we say, well, look, these foods clearly do protect you from cancer. Maybe the future would be, more specific dietary plans to give to people, or creating a supplement where you can put foods which we know have anti-cancer properties and give them to vulnerable groups. So people who have a family history of cancer, people who maybe who used to smoke or have already had one cancer, and do a study to compare whether they then get a cancer. And I think that would be a really interesting study if you could just give a simple nutritional supplement with whole foods and impact whether they get cancer, 5 or 6 years later. So, but it'd be an enormous study. I mean, you'd need tens of thousands of people over a long period of time. So you really need a lot of evidence to back that up before you start.
It is difficult in the nutritional world to do a randomized controlled trial, isn't it? But you are planning one in the near future.
Well, that one's a bit of a dream at the moment. There have been nutritional studies. There was the SELECT study in prostate cancer looking at vitamin E and selenium, and there's a lot of the vitamin interventions have been done. As you know, most of them didn't show a benefit because they used chemicals rather than whole foods, but that's a separate thing. We're in terms of what we've got on the horizon. The COVID study we've just mentioned, I can talk about that if you like. I think
you should. Yes.
So as you know, we were very pleased with our whole food supplement we developed about 10 years ago, and it showed an effect on prostate cancer. And from then, we've been working with various plant-based pharmacists and nutritionists. And we saw there's a lot of evidence actually from the last SARS outbreak of phytochemical-rich food, polyphenol-rich foods having direct antiviral properties. and there's all sorts of theories why they were not developed into drugs. Mainly we think that big pharma aren't interested because you can't patent them or intellectually protect them. But a lot of the foods like chamomile, pomegranate, etc., they work very similarly to the hydroxychloroquine, which is being investigated, I think inappropriately, to be honest. I think there's all this emphasis on a drug which is 20 years out of date and used for something else. And the elephant in the room is these foods have direct antiviral properties. They also improve, they're prebiotics, and they improve gut health. A lot of them contain nitrates, which are metabolized into nitric oxide, which improve tissue oxygenation. So there's all sorts of reasons how they could work and help people. The question is, of course, when you've got someone with COVID, can you change their gut and their internal environment quick enough to have an influence on the duration and severity of disease? And that's what we're asking in the trial. We know that those foods taken over a long period of time will probably protect you, but can you do it in a short intervention? And so that's what the randomization is. It's a capsule containing chamomile, pomegranate, turmeric, aloe vera, all sorts of things which came into the top list of antivirals. And that's blinded against a placebo, but an open element of the study is using a probiotic bacteria with mainly lactobacillus, which is the main sort of healthy probiotic, and probably the safest, because we didn't want to give a weird and wonderful one, just a safe probiotic. And that's open. So the Your Gut Plus are providing that for the trial, and that's actually what's funding the study, actually. So it's a good partnership there. The problem is we've only managed to recruit 16 patients, because we opened 3 weeks ago after taking the lovely British bureaucratic system 4.5 months to approve it in their fast track. Obviously, if we'd had it 3 months ago, we would have had patients, we could have probably recruited in 3 days. But fortunately, we haven't had a single patient come through our casualty in 3 weeks. So it's really fallen off a cliff. Saying that, if you know anyone who has recently become COVID positive on a swab, or has persistent symptoms such as cough or breathlessness from a recent infection, we can recruit from around the country, because it's all done via the telephone. So it would be nice to get the sort of 200 patients we need.
But we'll certainly spread the word, Rob. It's important work. The idea of food in a capsule is interesting. I generally tell people that the food is better than the capsules, but this is quite separate, isn't it? I mean, this is a sort of medicine in a capsule derived from food.
We don't like to use the word medicine when it comes to it, because it's classed as a food capsule, and sure. You're not allowed to make any medical claims.
Good point.
But obviously, the ideal is to get up, start the day with polyphenol-rich foods, nuts, avoiding sugar, and back that up with lots of salads and fruit for your lunch and dinner. But in a medical study, you have to quantify foods in order to get an outcome. So you can't just give someone a diet sheet. It's very hard to quantify whether people would adhere to that diet sheet or not. So supplements are very good for quantifying food. They can also significantly increase the intake of that food. So the capsule, for example, has a combination of whole foods and extract, not extracted chemicals, but concentrated extracts of the whole food. So it's quite tricky to have that amount, say, for your breakfast. So you take a capsule for lunchtime and breakfast and lunchtime, and you wouldn't normally have sort of that much pomegranate or turmeric or aloe vera in a standard diet. So you can enhance the intake. And especially when you're looking at endpoints such as the severity of a virus or markers of cancer, I think you do need that extra boost within a trial. Once the trial's been published, then people have the option of either taking the supplement or looking at their diet and increasing the amount of foods which was in the study. But that's their personal choice at the end.
I think one of the issues is availability of the foods that you're talking about in the populations that really maybe need it most. And I've heard some people say, well, the quality of the foods is diminishing anyway. The nutrient level, the benefit of nutrients is beginning to fall off in the way we actually grow our vegetables and so on. And then how are you going to get people who don't have access to fresh fruit and fresh vegetables in their supermarket? Because they're in an area which people just don't eat fruit or vegetables. So is there I wonder if there's a route in there for food capsules. Do you think we'll ever get to the point where we're actually advising food capsules instead of trying to influence our environment and getting proper food to the right places?
I'm always a bit suspicious of manipulating foods too much, because nature's a wonderful thing and the diversity is important. But you're right, you wouldn't normally start the day with broccoli, pomegranate and turmeric with your breakfast. So, and it's hard to, it may not be, it's not very practical getting hold of pomegranate, for example, and not everyone likes the taste of turmeric. So, there's definitely a role for that, but I don't think we'll go as far as some sort of Woody Allen science fiction film where we just take a capsule and it does everything for you.
Well, we're all, time is flying past, Rob. So, from your in terms of your cancer tips, top tips, I know you have that on your website, I think too, don't you? I mean, can you pick out one or two of your top tips to share with our audience?
You're right. On the cancernet.co.uk website, I do have this 20 tips to fight cancer, for want of a better word. I mean, I try to keep that updated. And most people are fully aware of most of them, but trying to go by the evidence, the other thing is to think about is what, over what period of time. I mean, most lifestyle strategies influence cancer over a very long period of time. So it's trying to get your children and you to change for the long term matters the most. And many people expect an instant benefit, and it often doesn't happen. Saying that, you can get instant benefits for how you feel after cancer, such as fatigue, joint pains, tummy troubles, chemo brain. But in terms of influencing cancer, so the ones which I think are number one is obviously exercising 3 hours a week, trying to avoid long periods of sedentary behavior. So if you have a desk job, to stand up and walk around. I gave a talk in the city of London last year, and I was very pleased they're all buying these stand-up desks and encouraging people to walk every 20 minutes. I'm a strong believer, although the data is not as robust as my beliefs, I think. I'm a strong believer of maintaining vitamin D levels, and I would advise patients to take vitamin D in the winter and try to get sensible sun and light exposure the rest of the year without sunburning, obviously. And then obviously the polyphenol rich foods, the ones we've talked about, broccoli, tea, herbs, spices, fruit, vegetables, and more than 5 a day. 5 a day is a minimal public health message. So with your cereals, plenty of berries. It's blackberry season coming up. That's a free organic food on every street corner or every sort of park corner. And then on the things to avoid, too much meat, burnt meat, sugar. Again, if you speak to a dietitian, they're never as convinced that sugar's as bad as I think it is, and probably you think it is. But there's a lot of evidence that processed sugar, not sugar in fruit, increases your chronic inflammation. It feeds the unhealthy gut bacteria, so you get a leaky gut syndrome type thing, which causes fatigue, chemo brain. And then can lead to other chronic diseases such as arthritis, diabetes. So I would strongly advise trying to cut out processed sugar as much as possible. Not a nice snack after your lunch or something, but certainly on an empty stomach where it has the biggest influence on your insulin levels. And we did it. You might be interested in a nice little study we did recently, where we had a lot of criticism from patients that you're telling me to stop sugar, and I walk into your cancer unit and all I see is cakes, biscuits, and sweets on every workstation. So I managed to persuade for a 4-month intervention that we got rid of all visible sweet items and replaced them with nuts and berries and fruit, which we paid for out of the research fund. And then we measured patient satisfaction, staff satisfaction, happiness scale, and weight. And we were very pleased in weight. And there is a bit of, there's a bit of a weight problem in the NHS, I have to say. And more importantly, the happiness really appreciated the effort made. And they said it gave them a good example. Can you still hear me? It says the...
Yeah, we lost a bit of signal there, but you can hear me okay, and I can see you, and you're back to where you were. I mean, all of that is great advice. Interestingly, this notion of changing people's perception. I mean, I think cakes and baking obviously took off in the COVID era, didn't it? It seemed to be this sort of comforting family, let's get together, we'll celebrate. It's a celebratory thing. There's a cultural thing about having processed food in that form. In my local charity, we have an annual coffee morning. And naturally, people want to provide baking. It's what they do. And people turn up every year and they want baking. That's what they get. So actually, a couple of years ago, I started putting out little cocktail packages of fruit in them, just a little bit next to all the baking. And in the first year, not very much went. In the second year, much more went. And last year, it all went. So it just little changes at a time can make a difference. And that brings me on to, just to finish off, that we do have this sort of notion of behavioral change as being fundamental. And we have this hashtag One Change campaign going. What sort of hashtag One Change would you like to see in the world? And also, what hashtag One Change are you likely to make in your own personal life, do you think?
Well, the one change would, I think, looking at the data, is snacking between meals. I think if you can just say, look, I'm going to have a good breakfast, and just avoid that, temptation to snack before your lunch. I think that will, and it's a habit forming thing. Most of us aren't. We get a little bit hungry, we instantly reach out. I mean, over the millennium, mankind have had periods of time where you've not had to eat constantly. So I think snacking it gives your stomach a rest, it lowers your insulin levels, it lowers inflammation. It's a great way to lose weight without even, trying too hard. So that would be, no snacking between meals. And I try to do the same. I'm good in the morning. I have to say, after lunch, I do reach for the biscuit tin quite a lot.
Well, that's not a good place to end it on, but I know what you mean. But the whole purpose, of course, is to make these small changes, and then the small change itself becomes a habit. And Well, Rob, it's been a real privilege talking with you. Thank you very much indeed. We're all looking forward to welcoming you as a speaker at our 2020 BSLM conference between the 3rd and 5th of September of this year, which in the COVID era will be virtual, of course. So meanwhile, to thank you for all our listeners for dropping in, and hope to have your company again soon. So goodbye, everyone, and stay well.